Because the
Right.
way we're gonna, it's
You
whatever
don't really
makes you
care,
comfortable,
right.
because we're gonna
Okay.
splice in.
Right, okay,
My number one thing is getting a nice, never event
Right.
quote. And then from there, I think the I think the clinical pathways approach, that quote, and then just whatever.
okay, right.
The main thing is to, I think, kind of exemplify our partnership in a video. We're
Right.
gonna do that symbolically by having a quote from you.
Right,
That's
right.
kind of what I'm thinking. So.
And Mike is talking to you, right, David?
Right.
Okay,
Right.
Okay, you're ignoring me, Mike, okay?
Right.
And we're
All right.
ready to go whenever you guys are ready.
okay,
Yep.
So, Mike, we have been showing that PowerPoint with that quote from you, which I've felt has been so powerful. If you want to just say that quote.
well, I'm really happy to be working with Magellan and your team on this effort to change our approach to suicide from something that we think of as inevitable to what we now understand is possible, which is to say that we should think of suicide in healthcare settings as a never event, like wrong site surgery or a surgery on the wrong person. We lose 100 people a day in the United States to suicide, and over half of them have seen a health professional or a mental health professional in the 30 days before they took their life. We understand now this doesn't have to happen. So innovations like Dr. Karen Cheney's efforts to manualize screening of people for risk and then connecting them with the right kind of care right away have got to become the norm. The reason why we don't have 100 people dying every day in airplane crashes is we've learned to automate those checklists. We find them a little bit obnoxious when we sit at the gate, but they are saving lives. And there's no reason why we can't do that in healthcare, and Magellan is helping us construct that path.
George, that's really all the kinds of talking points I'm looking for. Was it enough pauses in there that we can cut that up at all?
Yeah, I think so.
Okay.
Yeah, I think so. Is there anything else you might want to?
You know, I do this kind of thing, like the first time is as good as it's going to get. We can like recut it again, but it's not going to get any better.
Are there any other thoughts though, Mike? The main thing I was asking was make sure that we can piece that apart, and he's saying that absolutely there's enough space in
I
there.
think he
for
had
Right.
a nice flow, and I think he was really pretty consistent. He flowed real nice. I mean, I don't think he could change it.
Let me add one other thought that sort of goes to the other point that that you've made. Let's see, are you rolling?
Yeah, go ahead, Mike.
Okay. So we've thought of keeping people safe from suicide as something that was done by individual clinicians. But we have come to understand that it's a systems problem, that systems that commit to keeping people safe can keep people alive, just as the transportation industry, again, has kept people alive by using a more rigorous approach to airline safety. And this move from individual responsibility, where clinicians feel alone, they don't feel empowered, they don't feel like they have the skills, to one where systems give them support, provide them with protocols, and give them what help they need to keep people safe, is something that we've really got to commit to.
The only other thought, Mike, and again, we got a 3-minute video, so it's probably not going to make it, but I love hearing you talk about clinical engagement versus the natural sort of tendency to institutionalize folks.
Right.
Any thoughts on
Yeah, all right, so let me try that. Another thought that's come out of our collaboration is a fundamental reframing in how we approach people that are at risk. In the past, the main approach in mental health care when somebody was acutely suicidal is to hospitalize them. But we now understand that this, in many cases, is not helpful. We put them in a hospital. We don't actually treat their suicidality, although we're now understanding that there are ways to treat suicidality separate from their mental health issues and concerns. So we're starting to understand that hospitalization for suicidality, absent that treatment, is just like putting people in seclusion to keep them safe. We have got to engage them where they are. We've got to respond to their concerns. We have to help them develop plans to keep themselves safe, to reach out to us, to get the supports they need, and we can keep them alive if we do that.
That's great. That's great.
All righty.